A very good afternoon to everyone. I, Samriddhi Pednekar from the marketing team of Hetero Healthcare Main Division, welcome all the esteemed doctors to this informative webinar. Today we are here to shed light on the topic influenza and its prevention and the potential role of oseltamivir in children. To discuss this, I would like to invite our first speaker, Dr. Pramod Jog. Very good afternoon, sir.
Good afternoon.
Right. Dr. Zog has a very rich experience of 40 plus years in the field of pediatrics, has involved in various IAP activities, was President IAP Pune 2006-2007. Doctor has also received many awards. One of them is Best Outgoing Student of BJ Medical College, Pune 1980. Was a national trainer for Ask IAP. Doctor has been a faculty member in over more than 2000 national and international conferences, has publications in national journals and chapters in pediatric textbooks. So I welcome Dr. Zook. Also, I would like to invite our second speaker, Dr. Keur Mahajan, MBBS DNB Pediatrics, Pune, Diploma in Pediatrics Infectious Diseases, Oxford, UK. Dr. Keur Mahajan has been trained in Pediatric Advanced Life Support, Neonatal Advanced Life Support, Advanced Care Cardiac Life Support. Dr. Keur Mahajan is a consulting pediatrician and departmental coordinator in Maing Mangeshkar Hospital, Pune, and he is also a consultant pediatrician at at Child Care Clinic, Pune. Doctor has specialized interest in pediatric infectious diseases and respiratory diseases. So I welcome Dr. Keur Mahajan. Thank you, sir, for being with us here. With this, I would like to hand over the session to Dr. Zoe. Sir, please take it over.
Thank you. Thank you. So we will be discussing about influenza and prevention in today's program. And I'm glad that I have Dr. Keyur Mahajan, who is an infectious disease specialist, along with me to enlighten us on this particular topic. And I hope my screen is visible and I am audible. Keyur, am I audible? Thank you. Thank you. Okay. So now, today we will be discussing the pediatric perspectives. Basically, influenza is so common that anyone can catch this infection. So, as you all know, there are certain high risk groups, like, in case in a family, if there is a child who is unwell, then there are different members in family, like his parents, like the father, mother, then the grandparents, and children are the main source of this influenza virus. We have all witnessed COVID in 2020, 21, and 22, and we have seen that COVID usually transmits from adults to children, but influenza is the one which is transmitted by children to the other children and then to the other members of the family. It is very important because in a family, in case if there is mother who is say diabetic or father who has some respiratory problem like asthma, or grandparents who are obese or hypertensive, then they are in the high risk category, and that is why these children who have flu basically should not transmit the virus from them to anyone in the family, because they are likely to be at a higher risk. And that is why we should know different aspects of this disease, particularly in children. And that is the reason why we have chosen this particular topic for discussion. And you can see that every influenza virus, we all know that the flu virus changes its structure every year. And that is why this is the nomenclature of the virus which has been shown over here. By the way, the pediatric perspectives of flu, that is PPF, of course, which will be moderated by PPZ, that is Pramod Jog. And then this is the nomenclature. So you can see every virus has some name. Then there is a country or a place where it originates, then the month and the year when it originates, and the strain. Okay, so that 2016 is the year when I was the president of Indian Academy of Pediatrics, and every year the president keeps on changing, and that's why I was the strain of 2016. Anyway, that's in the lighter vein. Now we will go ahead and see as to some of these important points after having a look at a case. So we have in the OPD, 3-year-old boy. He has come to us with fever, cold, and cough, and the child is also breathless over these 3 days, and he is tachypnic, and the saturation at room air is 85%, and he is acidotic, and this particular child, after the X-ray is taken, is seen to have ARDS, and he is in respiratory distress. Okay, so the pediatrician, obviously worried, gets admitted to the PICU. The child is ventilated, and as a part of treatment, the child receives oseltamivir and supportive therapy. And you can see that after the throat swab is sent for examination, it shows H1N1 positivity. The child is ventilated for 3 days, and then he improves. So obviously, the treatment has helped the child. Now, the point is, we have started this child on oseltamivir, and that is why in a previously healthy child who presents with cough, cold, fever, who progresses over 3 days, okay, whether the clinician have prevented this particular progression, and whether, as we see now, oseltamivir has helped this child. So whether every patient of cough, cold, fever be given oseltamivir upfront, particularly in the flu season. So that is the point that we are going to discuss, and that's why some areas of confusion, as it is related to flu, I am just putting it as confusion, whether this is bacterial or viral. We all know that when a child gets cold and cough, fever, and when more than one system is involved, like the same child has watering of the eye, the same child has loose motions, the same child probably has rash on the body, that means more than a system is involved, then we call it as viral. When more than one member in the family is involved, that's also viral, like the father, mother, grandparents, the brother, sister, everyone. And then when more than one family is involved, so in the community, if Dr. Jog's family is unwell, Dr. Mahajan's family is unwell in a society, then it means it is viral. While bacterial infections are localized. So the child who has pharyngotonsillitis will only have pharyngotonsillitis. Usually he won't have pneumonia at the same time. So in the respiratory system also there is localization. While in a child who has viral respiratory infection, he will have mucosal involvement of the respiratory system in the form of tonsillopharyngitis. Maybe, he has laryngitis, he might have pneumonia. So all the parts of the system will be involved. So one has to be clear. So when a child comes to me with runny nose and cough, at the back of my mind, initially I am not much worried, because I know that this is, at least beginning as viral. Okay, now what that virus is and how this disease progresses further is a different story. Okay, the other area of confusion is whether this virus is something to be worried about. For example, in COVID, we were worried. But about rhinovirus, we are usually not worried. Though we know that rhinoviruses are known to aggravate some patients, asthmatic patients. Okay. Adenovirus, we were worried last year, and even today we are worried. And whether this is influenza. So we want to know which is that virus. And I always jokingly say that even Rajanikanth cannot identify what is the type of virus. Okay. That is because the presentation is so similar. Okay. And then if it's influenza, out of all these, what is the type, whether it is A or B, and how to find out. Okay. And whether I should start oseltamivir upfront, because we have seen over last few months and few years that because of these various respiratory infections, if a pediatrician in his busy OPD is unable to differentiate viral from bacterial, he just forgets the words like rationality and others, and he puts the child on amoxicillin or amoxiclav and also oseltamivir. So whether this is right or wrong, we will discuss it in the course of today's program. And that is why whether I should give every patient an antiviral to play safe. So these are all these areas, and that's why, is it possible to attribute cold, cough with fever to a particular virus? Now let us concentrate ourselves on flu. Now, true influenza is influenza virus A or influenza virus B. Type C is much milder, and influenza-like illness. Okay, so all those cases which come to our OPD on day 1, we put them as ILI, that is influenza-like illness. Okay, and it's caused by a variety of organisms, as we saw. But initially, we just say that it's a flu-like illness. Okay, but remember, influenza is the one which is called as father of all these influenza-like illnesses. Okay, and about 20 to 30% children, are involved in this particular influenza prevalence, and the burden in India, of course, is unknown. And remember that influenza virus is transmitted by aerosols. Okay, so when a person sneezes or coughs, at that time the virions are liberated, and within a span of about 72 hours, the person in contact gets infected. This is called as viral shedding. So it occurs by person to person transmission, primarily through contact with the respiratory secretions or the contaminated objects like fomites. Suppose if some person sneezes and uses handkerchief and keeps it on the table, and someone touches the table, then it's a fomite. So it's a transmission which occurs in different ways. And in children, the shedding of the virus continues for almost 14 days. In adults, it's only for 7 days. And if the person is immunocompromised, a person who is malnourished, or a child who is on steroids for some reason like nephrotic syndrome or many other conditions where the host is immunocompromised, the shedding is longer, and more severe the illness, more is the shedding. And that's why it is necessary that the shedding is controlled earlier. And oseltamivir, the antiviral, will reduce the shedding of the virus, and it will control so that the spread of the disease to other people also is less. And of course, body fluids and hand-to-hand contact leads to almost 70% transmission. And this particular virus can be destroyed by bleach or 70% ethanol. And as I told you, this infected person can shed the virus 24 hours before the symptoms begin, up to 7 days later. Okay, so it's a span of all those 7-8 days where we should be worried about the transmission. Okay, now in the OPD, there are many people come, and some of them are from the IT sector. These are the information technology people who are very clever, brilliant. They usually come, with a laptop and a Bermuda. I call them as Bermuda patients. They bang the laptop on the table and they start asking one question after other. So if I just say it's flu, then they say what type of flu, whether it is A or B, and then I have to be very well prepared. Of course, these IT sector patients, jokingly, I call them as not the information technology, but the inquisitive and the troublesome patients. Okay, this is only between you and me anyway. So this particular influenza virus was first isolated from a pig in 1931, and then in the human beings in 1933, and then classified by the virologists as, I will tell you in a minute. And there are 3 types of viruses, A, B, and C. And type A is the one which causes frequent epidemics. Okay, and these are due to minor antigenic variations. See, outside on this influenza virus, as I will show you in a picture, there are, some glycoproteins like hemagglutinin and neuraminidase. And if they show a bit of a change, very minor change, then this is called as antigenic drift. As, in case if the name of the person is Mayur, and if it changes to Kayur, most of the name remains almost the same. Okay, so that is a drift. And there is, a likelihood of another problem, and that is a shift. Shift means totally. So there, the name Keyur totally changes to Pramod. So there is no connection at all of these 2 words with each other. So the H1N1 virus suddenly becomes H2N2. So it may become H3N2, whatever it is. So these are the ones which are responsible for a major change. That is a shift. And this is nothing but the beginning of a pandemic. Okay. Type B usually produces only local epidemics, and usually, as it is only restricted to human beings, doesn't produce pandemics. Okay. Now this A virus, influenza A, has those glycoproteins, and when the virus enters into the body, some antibodies are produced against HA and NA, that is the hemagglutinin and neuraminidase, and different types of HA and NA with the permutation and combination, leads to different types of these HN combinations like H1N1, H3N2, and the earlier numbers like 1, 2, 3, they are usually in the human beings. But from the point of view of the birds and others, they are the higher numbers like H7, H9, etc. Okay, and only H1, 2, and 3 and N1 and 2 are commonly found in the humans. These are the earlier numbers like 1, 2, and 3. And the most prevalent human flu viruses are H1N1 and H3N2. And this is because the H1 and the H3 proteins, they recognize the human cell receptors, making it easy for them to split into healthy cells. Okay, so this is one reason why usually we find only the earlier numbers. These are orthomyxoviruses, and as you can see in this picture, hemagglutinin NHA and neuraminidase NA, they are the ones on the outer side. These are the glycoproteins. And you can also see that influenza B virus is the one which is found only in human beings. There are no subtypes of influenza B, and it causes less severe disease as compared to influenza A, and it mutates at a slower rate, and it's common in children between 5 to 17 years, and there is reduced rate of antigenic change, and combined with its limited host range ensure that pandemics do not occur with influenza B. Now, what these HA and NA do, that is something which we should know, because oseltamivir is the one which is called as a neuraminidase inhibitor. We should know as to what is exactly the thing that is done by HA and NA. Remember that hemagglutinin is the one which mediates the binding of the virus. So the virus enters from the nose, goes into the respiratory system and binds to the respiratory epithelial cells. So binding is dependent on hemagglutinin, and then neuraminidase is the one which is involved in the release of the virus from the cell. Okay, so these two are things. So when you give neuraminidase inhibitor, the release of the virus is prevented, and that is why the transmission of the disease is slowed down. And that is why, remember, we should know as to why these HA and NA, where do they come from? So usually there are 18 types of hemagglutinins and 11 types of neuraminidase, and all of them circulate in the birds, and the pigs are the ones which are called as the mixing vessel. I will tell you that in a minute. I already told you about the naming ceremony of these viruses. So the type of the flu virus, the geographic location, the strain number, the year of isolation. For example, type is A, the geographic location is Victoria, the strain number is 361, the year of isolation is 2011. So that is H3N2. Okay. So this is how the viruses are named. And remember, these RNA viruses, this is an RNA virus. It is a very naughty virus. And I always say to my, IIP president colleagues that, like IIP president, the flu virus changes every year, because the RNA viruses are known to have a change in the RNA. Okay. And that is why every year we have to have a different vaccine, because the same vaccine which worked in 2023 may not work for 2024. Though there is, usually over years, what we have seen is one of the, viruses changes. Say, for example, there is H1N1, H3N2. There is only a bit of a little change. Otherwise, 3 out of those 4 in the vaccine, they usually, I have seen, they remain the same. But that may not be the case every time. But then the structure changes. And you must know that the WHO keeps monitoring all these viruses from all over the world. And from 5 major centers, WHO receives the data about the viruses and then instructs the vaccine manufacturing companies to include those strains for that particular year. And in the southern hemisphere and in the northern hemispheres, these particular strains are reported to WHO, and depending on that, twice in a year, vaccines are brought into the market. Okay. And as I told you, we should know something about the drift and shift in a bit of more details. So the drift, as I told you, that means where Mayur changes to Kayur or something like that. This term denotes a minor change in the hemagglutinin and the neuraminidase of the influenza virus, and this results from mutation in the RNA segments, and this involves no change in the serotype. So there is only an alteration of the amino acid sequence. Okay, so H1N1, the name will remain the same. Only thing is that the amino acid sequence will change. But when there is a major change, that is an antigenic shift, okay, there won't be any immunity at all in the community against that new type. So if it is a virus which is H1N1 and suddenly changes to H3N2, none in the society has any protection against this H3N2. So there is no immunity to the new subtype, and that is why we have to be very, very careful when the influenza season begins. And as I told you, pig is the one wherein it acts as a mixing vessel. I always give the example of bhel. We all like to have bhel where there is murmura, sev, and papdi, and some onion and all. So all are mixed together. So in the pig's body, the viruses, the flu viruses from human beings, the birds, they all get together, and then there is exchange of the genetic material, and a totally new virus comes up. Okay, so this is a mixing vessel. So pig is the one where there is always some change which continues to occur. And then from the pig, you can see in this picture, from the pig the transmission has occurred to the human beings, pigs to the human beings, and then the human beings, they start transmitting amongst each other. So this is very important. So if those people who are in the vicinity of the pigs, They are the ones from where, we have to locate. So whenever there is an epidemiological investigation, people go back, start tracing as to where this virus came from. And usually they found that it is from the pigs. Okay. This same thing happened in 2009, where a novel flu strain evolved, which combined the genes from human, pigs, and the bird flu. And in the world, the epidemics, the pandemics rather, they started in different areas. 1918 was a very huge pandemic that was called as Spanish flu, okay, in 1918, and 1957, then 1968, 2009. Every time a new virus was seen producing the pandemic. And as I told you, influenza B doesn't produce pandemics, and so far no shifts have been recorded, and there is no animal reservoir known. That is the reason why pandemics are not seen. Okay. But in India, remember, the peaking of the flu season is mainly during the rainy season. Okay. See, during the rains and immediately after the rains, there are many cases of influenza which are seen by us pediatricians. And particularly in the north, west, and in east, we find these influenza cases peaking. And in south, we find that the cases peak in October to December. Okay. Now, clinically, influenza presents in a systemic symptom manner. What I mean? It means that there is only, in a rhinovirus, for example, only runny nose, and child will have mild fever and recover in 3, 4, 5 days. But here, there is systemic involvement. Respiratory symptoms are there, but the systemic symptoms like high fever, myalgia, muscle pain, malaise, weakness, headache, they are, more, and they are more than any other respiratory virus. So when a child comes to me in the season of influenza, in monsoon or in the post-monsoon period, then I always ask, does the child have headache? Mother says yes. The child has leg pain also. The child is weak. The parents are lifting an older child of 7 or 8 years, on the lap, and then they are bringing to the OPD. It means that the child is really unwell. Okay. A child with simple rhinoviral infection with cold and cough and mild fever is not to be lifted. So it's a systemic disease, and the isolated upper respiratory infection can occur along with croup. There may be a cough which has a typical sound with stridor, and the infection may spread to lower respiratory tract, and it may have additional GI symptoms. I told you, viral illnesses means involvement of more than one system, respiratory plus GI. Okay. Usually the febrile illness is for 2 to 4 days, and the cough persists longer. This is highly transmissible. And recently, I came across a family where initially children were involved, one child to other, then the parents, then along with them the grandparents, and the entire family was unwell for almost a month. So remember that this is highly transmissible, and you must understand that simple cold and flu are different. So the flu has sudden onset within few hours, and the headache is characteristic and more severe. So when the symptoms are out of proportion of the duration of illness, you must always suspect flu. Okay. Why this is important to know? Because then we are going to start oseltamivir on this clinical suspicion in the epidemiological setting. Okay. And between 40 to 85% of infections with influenza, they result in clinical illness, depending on age and the pre-existing immune status of the person. Okay. So it means that majority of them, they will present. So very few remain subclinical. And that's why you must have high index of suspicion. And of course, in the neonates and the infants and the prematures, there are particular clinical issues, and there are some differences between the adults and the pediatric influenza also. So the burden of the disease and the fatalities are, high in the earlier age. So 0 to 6 months, 6 to 23 months, 2 to 5 years. As I told you, it is the one which is transmitted from children to the adults. Okay. And you must understand that the viral shedding in case of adults, okay, is different than the viral shedding in case of children. I already explained to you this. And remember that the complications which are encountered in the pediatric population, they are definitely respiratory. For example, otitis media, okay, that occurs particularly 1 to 4 days after the onset of influenza symptoms. Then pneumonia, as I just told you, progression from upper respiratory to lower respiratory. Primary viral pneumonia, that means the flu virus itself produces viral pneumonia, and there could be secondary infection also. And I'm going to discuss with Dr. Keyur as to what is the incidence of secondary bacterial infections and pneumonias in particular, in a child who has influenza. Okay, so usually it's Streptococcus pneumoniae or Staphylococcus aureus co-infection. Why this is important to know? Because some of my immunology experts had told me long back that when a child with influenza gets bacterial pneumonia, okay, then in case if the child has received influenza vaccine, then obviously you prevent the influenza, and that's why obviously pneumonias as a part of secondary bacterial infection with, say, Streptococcus pneumoniae won't occur. Okay, so the importance of vaccination is that it prevents influenza, and as influenza is prevented, there is no superadded pneumonia in that particular child. Okay, and remember that respiratory complications also include exacerbation of asthma, and in some cases respiratory failure and acute laryngotracheal bronchitis. Some children might have toxic shock syndrome, cardiac problems like myocarditis, pericarditis, and then simple febrile convulsions or influenza associated encephalopathy due to cytokine dysregulation. Okay, and there is an entity which is known as acute necrotizing encephalitis, very particular to influenza, and some children might have Guillain-Barré syndrome and some might have aseptic meningitis. And with influenza B, myositis, particularly in children between 6 to 9 years, and particularly in boys, involving gastrocnemius and the soleus muscles, where there is severe bilateral calf muscle pain and inability to walk, and rhabdomyolysis. Many children come with muscle pain, and then you have to remember that if a child has onset with cold and cough and complaints of muscle pain, it is a part of influenza B. By the way, influenza B is not to be taken that lightly. From the data in the city, we have found that almost 30% patients of influenza in circulation are related to this particular type B. Okay, and there are some problems related to involvement of the liver, and gone are the days when we witnessed this Rye syndrome, where a child of influenza would receive aspirin, and then that would precipitate this hepatic involvement, leading to problems like hepatic failure. Okay, so remember that influenza is not that simple. Okay, and CDC criteria are there for suspected H1N1, where there is onset of acute febrile respiratory illness within 7 days of a close contact of approved case of H1N1. That means you have respiratory symptoms, the child has been diagnosed as H1N1, or the adult has been diagnosed as H1N1, and there is a contact, and this contact also has developed acute respiratory infection within 7 days. So that is the suspected H1N1. Okay, this is one of the points. Influenza-like illness is the one where there is fever with cough, and along with that there is fever more than 38 degrees, cough with onset within the last 10 days. That is the one that is influenza-like illness, the ones that we get in our OPD. But if the contact has been proved to have H1N1, then that is a confirmed case. And of course, there are cases of severe acute respiratory infection called as SARI, where there is fever beyond 38 with cough and onset within the last 10 days and requires hospitalization. Remember, one important indication for giving oseltamivir is any child with respiratory infection who turns breathless, not doing well, and hospitalized. He is, of course, justified to be given oseltamivir. Okay. Now, the CDC, WHO, and IDSA, that is the Infectious Disease Society of America, they recommend the diagnosis of influenza clinically and perform testing, particularly in hospitalized patients, as I told you, those who get admitted with influenza-like illness, but they have to be hospitalized. Okay, so they need to be tested by nasopharyngeal swab, and patients who died of an influenza-like illness, to clarify the etiology, to know whether this influenza is creating more problems, what is the strain, and then patients for whom decision about the infection control is a concern, particularly the nursing home residents or the child care and the healthcare workers. So these are some areas, and one of the most important ones for us, that is as pediatricians to remember, is that when a child gets admitted with influenza-like illness, please do the nasopharyngeal swab. And remember, there are certain high-risk groups. Remember, the pregnant women, the elderly, the children, the immunocompromised, the ones who have some other problem, they are the ones usually those who come in the high-risk categories. And for the benefit of all of us to remember, I have put all of them beginning with the alphabet C. So there are, some conditions where there is congenital or acquired immunodeficiency, cardiac or pulmonary or hematologic or renal or liver or diabetes as associated problem, chronic aspirin therapy, compromise due to neurologic disease because of the impaired ability to handle secretions. Okay. Corticosteroids for asthma. Charbi wale means, the ones who are fat. And chalo 70 means that, the elderly who are, after 65 going on to 70. Remember, pregnancy is one condition where you must be quite, careful, because flu is so common. If a pregnant mother gets influenza, then the, disease remains very severe. Disease becomes severe. She has to be hospitalized. Because of hospitalizations, there are so many problems, and the, lungs are involved, the tidal volume and other things are, affected, oxygenation is affected, and the baby who delivers also could be preterm and low birth weight, and the baby after birth also can have, problems like respiratory infection and so on. So that's why you have to be very careful. And there is a recommendation of giving influenza vaccine to pregnant mothers also in the second trimester, so that, the mother is protected during pregnancy, and immediately after birth, the baby also gets some amount of passive protection from the mother. Okay. And then there are certain grades of severity, like categories A, B, and C. To make it simple, if there is mild fever or cough, along with this, one needs to be just careful. No testing for H1N1 is required. And these are the ones where, there are usual flu-like symptoms. If there is a high-grade fever along with these symptoms and severe sore throat, it is usually put as category B. And in case if there is a problem where there is breathlessness and chest pain, drowsiness, and, signs of severity where there is fall in the blood pressure, hypoxia, and worsening of the underlying condition, then it is category C. Category C means serious. That means involvement of the lower respiratory system. And here, these are the definite candidates where you must give oseltamivir. And in children who have somnolence, excessive sleepiness, high persistent fever, inability to feed, convulsions, shortness of breath, difficulty in breathing, they need hospitalization. Please note these symptoms, because in children who are having fever, after 1, 2, or 3 days, if these things continue, then these are the red flag signs. They are the ones who need to be tested for H1N1, and treatment needs to be started. In the example that I told you earlier, where the entire family, was sick, and only when at the end, the treating pediatrician thought of testing in the grandmother, because, she was a high-risk lady with diabetes and obesity, then she was the one who got H1N1 tested and got positive. Then everybody came to know that the entire family has H1N1. So whenever the problem begins, if all these red flag signs are there, if the family can afford, and of course, if at all you are worried about that particular child, then it is better to get H1N1 testing. And remember, one should know that there are some investigations like the RT-PCR, which are done, most common. Of course, isolation of the virus in culture can be done, or some fourfold rise in the virus-specific antibodies also can be tested. But the most common one which is done is the RT-PCR. And then when we want to manage influenza, apart from supportive therapy, one should remember that it is not necessary to wait for lab confirmation of the disease if there is strong clinical suspicion, because oseltamivir is effective if started before 48 hours of the onset of disease. Okay. So if you waste time in checking and getting the report, or wait, let us see, let 3, 4, 5 days be over, then we will see, then the therapy may not be that effective. Though we know that from various studies, even if you start oseltamivir after 5, 6, 7 days, it does have a role, because the transmission of the virus, because it's a neuraminidase inhibitor, it is controlled, rates of hospitalization are reduced, the mortality also goes down. That's all. That's okay. But then it is better to start as fast as possible. And then there are antivirals like neuraminidase inhibitors and adamantinase. These are the ones which are available. Now, neuraminidase inhibitors like oseltamivir and zanamivir, they block the viral neuraminidase enzyme, which I just told you. They are the ones, these, are responsible. These enzymes are responsible for releasing the virus particles from the infected host cells. And they are the ones which are active against influenza A and B. Zanamivir is a powder that is inhaled and approved for early treatment of flu in people more than 7 years, that means children above 7 years. And new neuraminidase inhibitors, which can be used intravenously, are like Peramivir. Of course, oseltamivir is the one which was approved for medical use in the US in 1999. It was the first neuraminidase inhibitor available by mouth, and it's a selective inhibitor of the neuraminidase enzyme of the influenza viruses A and B. And oseltamivir is a prodrug which gets converted to the active form, oseltamivir carboxylate. This occurs in the liver, and it inhibits the release of the virion from the host cell and prevents the further spread of infection. And what is the mechanism of oseltamivir? As I told you, it halts the influenza viral particles' ability to spread to the new human cells. And that is the point we must remember. So the transmission to the community is stopped, transmission within the family stops, and then the control of the symptoms is reduced. And it has been found that it reduces the duration of illness by 1 day. Okay. And we remember that it reduces the risk of otitis media. There is reduction in the risk for lower respiratory complications, duration of hospitalization, the severity of the complications which require mechanical ventilation, and then even later in the course of illness, it is supposed to be beneficial. Okay. So the recommended doses depend on the age and the weight. Under the age of 1 year, between 3 months and 12 months, they range from 12 milligrams to 25 milligrams. And the dose for therapy is to be given twice daily. Okay. And particularly above, 1 year, it is again from 15 kg to adult age. It ranges from 30 milligrams, 45 milligrams, 60 milligrams, and 75 milligrams. This is again twice daily. And we have preparations which are very convenient, like, even 30 milligram capsule is available, which can be conveniently given to an older child. There is a prophylactic therapy where, pregnant mothers, persons who are at a high risk of complications of pneumonia, all those C's that I told you, and the healthcare providers, particularly the doctors and the emergency medical personnel who are not vaccinated. So they are the ones who require chemoprophylaxis. And remember, chemoprophylaxis is to be given for 10 days, and it is only once daily. The dosages are roughly the same, but it's the, once daily therapy. And that's why, remember, therapy for 5 days, prophylaxis for 10 days. Okay. Whether this medication is tolerated well, in general, it's tolerated well, except that some of the, patients, they may get nausea and vomiting. And in case if there is a known hypersensitivity, one has to be careful. Severe allergic reactions have included anaphylaxis and serious skin reactions also, including toxic epidermal necrolysis, Stevens-Johnson syndrome, and erythema multiforme. One should be careful about it after giving the medication. Okay. And then whether we can use this on suspicion. So remember that the tests are not recommended in routine cases where there is mild flu category A, and you can use the medication before 48 hours, and whether we can use it on suspicion. But remember, it has to be in the epidemiological setting, and one must have a strong suspicion. Simple runny nose and mild fever, no oseltamivir. But the child has headache, he is, shouting with muscle pain, he has weakness, he has high fever, 4 or 5 days he is unwell, he is somnolent, not eating well. So remember, we have to be very, very careful. That is because, as Alexander Fleming said about penicillin, that particularly the thoughtless person who uses penicillin irresponsibly is the one who will be finally responsible for penicillin resistance. Similar thing would be true about oseltamivir if it is used indiscriminately. So no indiscriminate use at the right time. But even if you use late, it is okay, because it is better late than never. And be aware of the limitations of the drug, including adverse events, and there is no role for chemoprophylaxis unless there are specific risk factors which I just told you. So what are the recommendations for using oseltamivir? For category A, you have to just give symptomatic treatment, avoid aspirin, and reassess after 24 to 48 hours. Then category B, where you have to have home isolation, full course of oseltamivir, and if required, then maybe antibiotics. Okay. And category C will require oxygen, airway, breathing, circulation maintenance, then maintenance of hydration, electrolyte balance, nutrition, mechanical ventilation if required, and broad spectrum antibiotics if required, and full course of oseltamivir. Okay. So remember that this virus is fast and furious. The onset is abrupt, transmissibility is high, the progression is rapid, ARDS develops fast, the child may get vertical discharge very fast. That means the child may die. And that's why oseltamivir is the only thing which needs to be started early. And in addition, you must follow cough and sneezing etiquettes, like coughing or sneezing in the handkerchief, or coughing in the elbow, which is called as Dracula cough. And you have to keep the hands distance. I call this as Hasta Sutras, and then you have to remain a bit away, at least at a distance of 2 arms from the person in front of you. We have learned all these during COVID. And that is why with all this, I appeal to follow all these preventive measures also, in addition to the vaccination. I always say that every birthday, one must take the annual shot of flu vaccine. So I say, in addition to happy birthday to you, I also say happy birthday to flu, because the last alphabet in flu is U. And I always say that the flu ends with U. And that is why, in addition to those preventive measures, Hasta Sutras, okay, you must take the vaccine, and also see that children in particular under the age of 5 definitely are given this vaccine, more so if they have some additional medical complication. With that, with folded hands, I request you, appeal you to follow all those Hasta Sutras, take the vaccine, and whenever you come across a child with suspected flu, who is in the category 2 or category 3 or hospitalized, better start with oseltamivir on time. Okay. So with that, I stop sharing the screen, and now I will request Dr. Keyur to have some dialogue with me related to the infectious disease specialty that you have, because I will tell you, in practice, as I told you, people are many times not very clear about whether this is flu or whether it is something else. And that's why the trend of giving antibiotic along with antivirals is seen to some extent. Okay. So I would like to have your candid opinion as to how a pediatrician should approach, because it's quite natural, not okay, but it's natural that the pediatrician, under stress and tension of the crowd in the OPD and inability to diagnose clinically, is mentally compressed or stressed, and then in the that particular pressure, he writes both of them. So how would you approach a child who is having undiagnosed, that means by the lab tests, of course, clinically he may suspect, he may not suspect, approach to a child who has come to you with a respiratory infection? So you can just explain that.
Yes, sir. Thank you, sir, for such an elaborate lecture and giving so much pinpoint things on flu. And thank you for allowing me for this session. As we know, as the season will be picking from June and July, and we will having more and more patients with respiratory tract infections. And this is also peak season for influenza activity in our area, because we fall as India, though we are a tropical country, but WHO enlists us in the southern hemisphere, and we have a southern hemisphere activity for influenza season in our Pune and around city in India, except some few states like Kerala, Tamil Nadu, and Jammu and Kashmir, who behave like northern hemisphere, but in other states they behave like southern hemisphere. So we will having the peak activity. So whenever patient comes to us in our OPD with complaints of high-grade fever, cough, cold, or throat pain. So as we know the basics of differentiation between viral and bacterial pathology, as we know that in viral infections, other mucosal involvement will be also there. So that is also important point. We can see the conjunctival congestion is there, the mucosal congestion is there. Child may be having some diarrhea. So there is sudden onset of high-grade fever. Usually in viral fevers, the fever is in sudden onset, and high-grade bacterial infections usually is in gradual onset. Okay, so so also on throat examination, we may see that there is mucosal redness, mucosal injection is there. But in bacterial infections, we may see or may not see tonsil exudates or pus pointing. So these are the clinical indications, how the fever is progressing, how the child is presenting, what are the other associated symptoms like cold, rhinorrhea, and other mucosal involvements are there. So that will help us to differentiate between viral and bacterial infections. But as you said that because we sometimes we could not differentiate viral and bacterial, so we tend to add antibiotic, thinking of he may have a secondary bacterial infection also. So, but as I have gone through different studies in which they have shown that rate of secondary bacterial infection in influenza, there are different studies quoting different incidences ranging from 2% to as high as 35% also. But there is large one, there was large one meta-analysis which were conducted, and they found that secondary bacterial infections are common when when we have lower respiratory tract infections rather than upper respiratory tract infections. So most of the patients what we are seeing in our OPD are upper respiratory tract infections. Okay. So if we are thinking of, if you are thinking in viral etiology, then for upper respiratory tract infection, the secondary bacterial infection is very rare. The incidence is very low. But if the child is admitted and is having low respiratory tract infection with influenza, then the chances of having superadded bacterial infections are high. So in those patients, you are justified adding back antibiotic to cover. But in OPD basis, when you are suspecting viral, the viral epidemic is going on, epidemiologically there are viral infections going on, and you are seeing the child who has a viral picture. So to add antibiotic is not good, because as we know, we are in an era where we need to use our antibiotics very cautiously.
Right, very good. So thank you, Keyur, for clarifying it crystal clear that in the upper respiratory infections, usually if you are suspecting that there is a viral infection, the chances of superadded bacterial infection are not at all high. And in the lower respiratory infection, maybe viral lower respiratory infections, the chances are there. And that's why a child who is admitted may be given antibiotics, that too, after proper consideration. Because many times a hospitalized child usually is on IV fluids, or maybe, people give them antibiotics like amoxicillin or amoxiclav. That's a different story. So there one may, be justified, or maybe, he might be right in giving. Okay, that's very good. Now, another thing, Keyur, I wanted to know is, influenza is a virus which can always be, rather be diagnosed by nasopharyngeal swab. And, there are other viruses also which are diagnosed after the nasopharyngeal swab examination. These days, there are panels also. And so many people, particularly, if the child is, being rather treated in an institute or at a corporate hospital, many times, just because the thing is available in the hospital, people just casually say, okay, thoda sa wo respiratory panel karke aao, so many times, for various reasons, people, go ahead with all these things. Anyway, the point is, there are different respiratory viruses, as we saw, maybe rhinovirus, RSV, adenovirus, influenza, parainfluenza, and there are viruses which affect the upper respiratory tract as well as the lower respiratory tract, because all of these can affect both. So, many times some of these viruses are likely to be commensals, or, they are always there, always there. And there are some ones which are really ones which are to be worried. So, would you like to throw little light on which are the viruses found in the nasopharyngeal swab, about whom we need not worry too much, and which are the ones where we should worry, and just clarify some of these points.
Sure, sir. Thank you, sir. This is a very nice question, because as you told that post-COVID, the PCR tests are very easily available, and apart from one standard panel which we used to do, I will not quote the name of the company, but other local PCRs are also available, which are non-standardized PCRs, and people are doing that. So, but as we know, the nasopharynx is a very complex environment. And it is also a dynamic environment. It keeps the common organisms in our nasopharynx keep changing. So it is a complex and dynamic environment. And when we do PCR and when we get some virus on that, and we may think that is it really pathogenic or it is just commensal. So it just short. This is not hard and fast. But what are true viral pathogens, which we should suspect that this may be true etiology, like in RSV, influenza, parainfluenza, and human metapneumoviruses. So these are the 4 viruses which, if present, usually are true viral infections. And other viral infections like human Boca virus, then adenovirus. Adenovirus may be present, but it may be true pathogen also. But problem with adeno is that it after infection, it may remain in nasopharynx for so many months, even for years also. So it may be not the pathogenic organism for that current infection. Okay. So other viruses like rhinoviruses, enteroviruses, non-SARS human coronaviruses. So these are the other viruses which are usually common cells. So we should be very cautious while labeling these viruses as a true pathogens. Similarly, in bacterial also, the strep pneumoniae, H. influenzae, staph, which are the commonest organisms causing bacterial infections, can be also commensals in nasopharynx. So we have to be very cautious when we are conducting a nasopharyngeal swab, and if we are finding one organism, to label it as a causative organism, we should be very cautious.
Okay, thank you very much. Just for further clarity, out of these three, bacteria which we commonly say, the Streptococcus pneumoniae, H. influenzae, Moraxella, staph also. So, in case if you get Streptococcus pneumoniae in the throat swab, what are the chances that it is a commensal or it is always a pathogen? Same about H.
No,
influenzae.
no. It can be commensal also. You have to correlate with your clinical features. As we had a epidemic of scarlet fever in last 3-4 months. So the rapid antigen test people used to do. So the only thing that you have to corroborate, it is just evidence that Streptococcus is present in your throat. It is not the evidence that it is causing disease to you. Okay, so for that you have to go clinically. You have to see whether really there is tonsil pharyngitis is there, whether it is bacterial. The picture is looking like bacterial. Whether he is developing some scaletifem rash or not. Whether he in a future course develops some exfoliation or not. So presence of just streptococcus group A streptococcus in throat does not indicate that it is the pathognomic. But there are certain bacteria like Klebsiella pneumoniae, Legionella pneumoniae, Mycoplasma pneumoniae. So they are to be taken more seriously if they are present. But these strep pneumoniae, staph, H. influenzae, Moraxella catarrhalis, these bacteria can be big. They can be commensals also. So you have to be very cautious while taking into those considerations.
Right. And I'm sure this Corynebacterium diphtheriae, that of course is a pathogen, because that's something, of course, we have now stopped seeing, this organism over so many years. But now, even though I read one article, it is down but not out. That means, it is less, but in some areas like Karnataka and all, diphtheria also continues to remain. And now this is about the nasopharyngeal swab. But what about the lower respiratory tract, where sometimes people say that you have to diagnose by taking a bronchoalveolar lavage and so many things. Of course, not in our practice. But then, have you ever rather I'm sure you must be ordering these tests when a child comes to you with pneumonia. But then, what are the situations where you need to have those lower respiratory secretions for finding out these organisms? What are in your practice like?
To do bronchoalveolar lavage in the children is very difficult.
Right.
So use it very rarely. Okay. What we can use is minibal. Minibal is a technique in which just the catheter is inserted through endotracheal. Minibal is also done in the children who are intubated. Okay. So through that endotracheal tube, we insert the catheter and we flush with some normal saline and we aspirate the sputum and we send it. It is called as minibal. What commonly is done is endotracheal secretions. Just by suctioning, we can take the endotracheal secretions. So yes, in children whom we don't have any obvious answer, who are not responding to our routine empirical treatment, and those who are obviously having lower respiratory tract infection, and we are not sure what we are doing, so in those cases, definitely we can send these ET secretions or minibal secretions for the multiplex PCR. And yes, sometimes those multiplex PCR do help and give us some clue about the type of treatment, duration of treatment. So definitely in such patients, multiplex PCR helps.
Okay, that's very good, because I remember, some of our colleagues have seen cases of, respiratory infections, which later on became low respiratory, and then there was lobar pneumonia like picture, and the child was put on ceftriaxone, and even after 5, 6, 7 days of ceftriaxone, the patch would simply remain like that. Child won't respond, and after the test for the PCR was done, it turned out to be adenovirus. And adenovirus is supposed to be quite presentation remains quite similar to this
Similar.
lobar pneumonia.
Right,
Even the
right.
CRP is supposed to be high with adenovirus. Lobar pneumonia like picture is there. So there, they after they checked the secretions, then it was shown to be an adenovirus. And as you said earlier, it can remain there for a long time also. So some of our friends from Navi Mumbai, they always tell me that it can remain for 2 weeks, 3 weeks also. So this particular virus is quite notorious. And last year and this year, we have been witnessing some of these cases, though not
Yeah.
commonly. But then there are even one of my friends from Kolkata, he mentioned similar case. So different people mentioned similar cases where the presentation was like lobar pneumonia, but later on it was proved to be adenovirus. And then this actually finally what happens is once you know that this is adenovirus, at the back of the mind you are relatively comfortable. Otherwise, you'll feel that, otherwise people will keep on changing from ceftriaxone. They will add something more. Vancomycin will be added, this, that, and antibiotics will continue to be, escalated. So at least this H1N1 will give some mental peace that this is not, something where there is a resistant organism, isn't it? Anyway, that's very good that you told us in details. And one more thing is that just tell us the OPD situations or maybe indoor also wherein now today we are discussing about flu and oseltamivir. So where specific indications, of course, I have told some of them in my talk already, but then as an infectious disease specialist, what is the stage at which you start oseltamivir? What would you tell to our listeners from your side?
So as you have discussed that if we start oseltamivir within 48 hours, it is most beneficial. It will reduce the duration as well as symptomatic improvement. So whenever there is so prescribing oseltamivir, we have to keep the what is going on outside. What is the epidemiology going on? In which months we are treating the patients? What is the influenza picking season in our area? So in those scenarios also be kept in mind. That is like what we say the what is probability that this child will be having influenza like illness or influenza infection. So that has to be kept in mind. So not only so the clinical features, how the child is presenting, what is the epidemiology. If the child is presenting in June, July, August, September, which are the peak season of influenza, then my threshold for writing oseltamivir will be low. But if the similar child is presenting in February, March, April, May, so these are the months which are very low influenza activity. In those months, or when there is no influenza activity going on in the community, during those seasons, my threshold for writing influenza will be high. Okay, so again, as you are told that the viral illness will present with a high grade fever, sudden onset high grade fever, associated with other prodromal symptoms like rhinorrhea, conjunctival congestion, associated diarrhea. So other mucosal involvements also there. High grade fever is there. Epidemiological circumstances are there. Peak seasons, influenza activity is going on. In those patients, definitely I will start oseltamivir within 48 hours. And again, as you discussed that category B and C are there, those who patients are indoor admitted and having low respiratory tract infections with respiratory distress, oxygen requirement. In those patients also without testing, we will definitely think of adding fluvir. And also, of course, we will send the test because if the child is having H1N1 infection, we may need to isolate the child from other children. So for indoor patients who with low respiratory infection who fall in category C or in, so we need to send the test, but we don't need to wait for the result. We need to start the treatment. And if the child unfortunately comes H1N1 positive, then we can segregate the child from other patients. Also, we can if we can think of giving prophylaxis to family members. So that is also one of the important aspect of testing for H1N1.
Right. Thank you very much. So most of the doubts are now clear, and I think from our side we will take a halt And Dr. Prashant, if you have any questions from you or from the audience, please feel free to
Yes, sir.
ask.
Thank you very much. It was a wonderful session. Wonderful. One thing I like specifically is the word "you" and "flu." I mean, it goes very well. Sir, one thing: if a patient is vaccinated, would the prophylaxis help further? Vaccinated for flu, would prophylaxis help?
Yes, prophylaxis will help because as we know that the antibody titers after vaccination, as we were thinking of, previously are lasting for 1 year, but now more and more studies are coming up that the antibody titers are not lasting for that longest duration.
Okay.
So what are the indicators? The CDC guidelines and other guidelines do suggest that whether you are vaccinated or not vaccinated, if you are exposed to influenza, a person having influenza infection, so you may get chemoprophylaxis, and it will definitely do.
So it's beneficial there also.
Yeah, it's definitely beneficial whether you are vaccinated or not vaccinated. So it doesn't count. You can take chemoprophylaxis.
One of the greatest benefit of this treatment is that if you give prophylactic treatment to the child, you are likely to prevent a very serious disease in the elderly patient because of transmission.
As I said.
Yes, because that's very. I mean, we miss this sometimes, and most commonly, the first thing of infection comes is a bacterial infection. I mean, virus always takes a backseat. I don't know why, but antibacterials always.
Yes, you're right. Many times, people immediately think of starting amoxicillin or amoxicillin. Yeah, they don't think of starting oseltamivir.
In fact, if an microbial has to be started, one should consider antivirals first, as commonly as antibacterial, depending on the epidemiology, of course.
Yes.
And another thing, if you start the prophylaxis with oseltamivir, apart from duration, would the intensity of illness come down?
For prophylaxis or for treatment, you said?
Yeah, prophylaxis. Both, in fact, prophylaxis and treatment, if you start.
Yeah, of course, in treatment, the intensity and duration of illness will reduce if you start early.
Yes.
Definitely, it will definitely.
And prophylaxis?
Prophylaxis, definitely it will help, but I'm not sure about the actual what certain, because what they say if you start flu in 48 hours, the duration of illness will. There are studies being done which are showing that at average 24 hours duration of illness will cut down. But for prophylaxis, I'm not sure how much duration. Right. Definitely it will help, but I'm not sure about the duration, how much it will cut down.
Yes, but certainly it will help.
Yeah, it will help. And Prashant, I must say that I was just telling about that pregnancy.
Yes.
Many times pregnancy is a condition where you must prevent influenza.
Absolutely.
If a child is having a problem in the family, and if the mother gets flu, then I have seen so many obstetricians literally, becoming very tense because the mother gets hospitalized, and then, so many problems come up.
Yes.
The baby also gets affected. Yeah.
So despite with all this, there is a little hesitation in the use of oseltamivir, I mean, clinically.
Yeah.
The first,
I know.
Thank you so much. Yeah. Thank you so much, doctor.
Yeah.
Thank you. It was a great insight into the antiviral therapy and benefit with oseltamivir. Thank you very much. That's all from my side.
Thank you.
Thank you.
Yeah. Then maybe from your end, our colleague can conclude.
Yeah. So thank you for addressing the questions, and I hope a lot of queries still unquestioned would have been addressed from the participants' end point of view. Therefore, on behalf of Hetero, I extend my gratitude to all of you. Thank you, Dr. Zog. Thank you, Dr. Mahajan. And to the participants, Dr. Khandeparkar, thank you very much. And also thank the entire IT team for supporting us. Thank you, sir. Good day.
Thank you.
Right.
Thank you.
Thank you.